Tata. Okay. Good morning. I am Dr. Thambu. I am from CMC Vellore, and I will be taking a session for you all this morning called Biological Inferences. This is part of a series on epidemiology, which is a study of human beings, what causes disease, how we can prevent it. So that's the major focus of epidemiology. Today's topic, biological inferences, deals with looking at data which is presented and making sense of it. Does it have any clinical relevance? Does it have any public health relevance? Does it have relevance to your hospital? Or is it data which may not actually be actionable or should not be acted upon? So with those brief words, I'd also add that if you have any questions, please stop me. If I'm going fast, please send me a message. So we'll get started. An interesting quote by William Cameron: not everything that can be counted counts. Not everything that counts can be counted. So some people say only with data we can work. Without data we cannot work. And often the data may not be good quality. And often for decisions we have to make, there may not be data at all. So what are the objectives for this session on biological inferences? First, I want you to be able to describe the sequence of events that happens when we're thinking about etiology. Is this really something which causes disease, or it is not really something which causes disease? I want you to be able, at the end of the session, to differentiate between real and spurious associations. Third, when do we say that something causes something? Currently, we have a newer understanding. Some things may be necessary to cause disease. Something may be sufficient to cause disease. Fourth and finally, how do some other countries deal with it? So the example I've taken is the US Surgeon General, who has to make decisions about whether smoking causes lung cancer, whether some new drug is safe or not. How do they make the risk-benefit relationship? So that's what we're going to cover in the next hour and so. So by way of introduction, you have already completed different types of epidemiological study designs. I understand you have already learned about observational studies, like case control studies, cohort studies, cross-sectional studies. The whole goal of these study designs is to look and see whether, for example, smoking causes lung cancer. Smoking in this example is called an exposure, and lung cancer is called the disease outcome. So I'll frequently be using the words exposure and outcome. Exposure is a sort of risk factor. Outcome is what you're really interested in, what you're trying to study. How do we know that smoking causes lung cancer? We have to quantify it in some way. And I understand you have already learned about relative risk and odds ratios. These are frequently used in statistics and epidemiology to show how much more risk is there in people who smoke as compared to those who don't smoke, or any risk factor you're interested in. So relative risk and odds ratio are a topic worth revising because that is frequently used in all methods of epidemiology. As I mentioned in the beginning, just because the relative risk or odds ratio is increased, it does not mean that smoking causes lung cancer. It may just be associated. The two may happen to happen at the same time, in which case still the relative risk and odds ratio will be increased, but it does not mean that A causes B. So the difference between an association where two things happen at the same time and A causing B is a huge step, and I hope at the end of this talk that will be clearer. Let's recap. Let's look at somebody who has an environmental exposure, somebody exposed to the atom bombs in Hiroshima and Nagasaki. And you want to know, are they having more cancers later on? That is the environment you see, and the outcome is cancers. So if you look at it, you will find the relative risk of those exposed to atom bomb and those not exposed. And you may find that the risk of cancer is 2 times or 3 times among those exposed to a nuclear explosion. Does that mean nuclear explosion caused cancer? And that is where we say we move from an observation or association to causality. And that's the story of today's class. So, how do scientists do in the laboratory? If you want to know whether smoking causes lung cancer, you can take an animal and expose it to cigarette smoke. You can take some other animals, let's say mice, and keep them as controls, not exposed to cigarette smoke. And then you can look at the end of it and see whether the mice exposed to smoking had more cancer. Thus, you will get an odds ratio or relative risk, and you can reasonably conclude that smoking causes lung cancer in mice. But can we extrapolate that to human beings straight away? That jump is difficult. Similarly, now with cell cultures and organ cultures being more common, we can do research on human cells or human organs which we can culture. But can we directly extrapolate what happens to a cell, a human cell in a petri dish? Will that be the same response you have to the human being, a whole human being? That's a difficult jump to make. But that is the jump from lab to bedside. Is it ethical to take human beings and randomize them? Some smoke, make to smoke, and some not to smoke? No, it is not. So it's often difficult to find out causation, especially of harmful substances, by human experimentation. That is where we go back to the observational studies I mentioned about in the introduction, case control studies and cohort studies. So what basically are these case control, cohort and observational studies? We observe human behavior, we observe nature, we see natural or unplanned events happening and we take advantage of them. For example, the Bhopal gas leak was a big tragedy. And we want to know, did that gas leak have a bad effect on the people of Bhopal? So we can take the people of Bhopal who are exposed to the gas leak as cases. And we can look at the people of some other city which did not have a gas leak as controls. And we can follow them up for some more time as a cohort. And we can see whether there were more cancers in the people of Bhopal as compared to the other city, let us say Chennai. This would be one way of doing a cohort study, a follow-up of people exposed and unexposed. A case control study, you take people from all over India, some who have a cancer of your interest, and some who don't have the cancer of your interest. And you can see how many of the cases were exposed to the toxic gas of Bhopal, and how many of the controls were. And again, you can get a relative risk or more probably you get an odds ratio in a case control study. So these are where we don't do anything. It sounds horrible, but an accident happened in Bhopal. A bomb happened in Hiroshima and Nagasaki. We are taking advantage of a natural or unnatural event to study something of our interest. So we rely largely on the documentation of what happened to human beings before and during and after that to make inferences. So, as I mentioned, this is the usual sequence of biological inference. We observe something. That's the starting point. Then we say, oh, do we have some information, some data, which we can use to make some scientific guesses? Otherwise, people are making all sorts of inferences without trying to collect any data or analyzing it. And that is dangerous. So, for example, we collect data on people from the Hiroshima and Nagasaki area and follow them up after the nuclear bomb and see how many of them developed cancer. Then we look at Tokyo, which was not exposed to the nuclear bomb, and we follow people in Tokyo and see how many of them had cancer. So we have a clinical observation, there was a bomb, and we have data available. Then we do a cohort study, which is what I explained just now, following up people. Or we do a case control study, where we see people with cancer and without cancer, see how many were exposed to the bomb and how many were not. And then we try to make inferences. At the end of it, if it is ethically possible, we try to do randomized control studies. How do you do randomized control studies of causality? Well, you can take a group of smokers, for example, randomize them into two groups. One group is given the common advice by the doctor, please stop smoking. Another group is taken and they sent to a group of counselors, health educators, and given much more intensive advice to stop smoking. The routine practice as of now is a doctor advises the patient to stop smoking. So you're not doing anything unethical. Many years down the line, you can see how many cancers developed in both groups. And if there are less cancers in the people who are advised to stop smoking and who subsequently, we hope, stop smoking, we can then infer that smoking was a possible cause of cancer. So we can do randomized controlled studies in some situations of harm as well. So it's a two-step process, which I have described so far. Obviously, you need to have data. Without any information, we can't do anything in the science of epidemiology. But as I mentioned, every decision, if the absence of data doesn't mean we can't make a decision, because we have to make decisions in some situations. Assuming we have some data or some evidence we have collected, the first step is to see, is there an association? Does A happen very commonly with B? Does cancer happen more commonly with people exposed to a nuclear bomb as compared to people who are not exposed to nuclear? And that could be done at two levels. What I have described so far, looking at people from the city of Hiroshima and Nagasaki and their cancer subsequently, as compared to those who are exposed to no nuclear bomb, let's say Tokyo, and following them up for a while. Those are called group characteristics. We're studying the whole city of Hiroshima and Nagasaki versus the whole city of Tokyo. These are also called ecological studies. We can also do individual studies. And as the examples I'll come to in a little while, you can take people with pancreatic cancer. You can take individuals without pancreatic cancer. And for example, if your hypothesis is that coffee causes pancreatic cancer, you can simply ask the people with both with and without pancreatic cancer how much coffee you had or didn't have, and then you can try to make some association. What is the relative risk, or what's the odds ratio of smoking and coffee and pancreatic cancer? Similarly, once you made this association, and you know from previous lectures that if the relative risk or the odds ratio is more than one, then you say, oh, there is an association. If it's less than one, similarly, we can say that it's harm. Then the next step is this a chance association or is it really causal? So there are two steps to making biological inferences. One is there a risk at all? Is the relative risk or odds ratio significantly more or less than one? And the second step is, if there's an association, is that really causal or is that a chance finding? This cartoon tends to explain a little bit. And this is from the Leon Goddard's textbook of epidemiology, which is the prescribed textbook for this course. So on the cartoon on the left, you see someone saying, someone sent me an anonymous email with a link about the world's worst bosses. And every time you get up from your desk, I see one of these mails. So is this a correlation you didn't think I would notice? Assuming that the person who got up from the desk sent the email to the boss. And there's a comment from another person. Correlation doesn't mean causation. So just because the message of the cartoon really is, just because two things happen at the same time or around the same time, it doesn't mean that one caused the other. So building on what I said, therefore there must be two types of association. One is real and one is not real or spurious. When is spurious? Take for example, I want to prove, this is a hypothetical story, that smoking has nothing to do with lung cancer. I can choose a group of lung cancer patients who never smoked. And I can carefully choose a group of controls who I know smoked. And I can then prove that actually smoking doesn't cause lung cancer, or even smoking protects you against lung cancer. So poorly designed studies, I'm not saying that all the time people do fabricated work, but by accident, you don't choose cases or controls properly, then you may land up with a wrong story. So how do you know then that your case control study has been designed properly? Let's take, for example, the story I told you earlier of pancreatic cancer. And there was a large study which said that coffee drinking causes pancreatic cancer. So the cases for people with pancreatic cancer, the controls were those without pancreatic cancer. And they looked at history of coffee consumption. And they found that the relative risk or odds ratio for coffee drinking was much higher in the people who had pancreatic cancer. But what they failed to notice was among controls, people without pancreatic cancer, the amount of coffee drinking was far less than the general population. In other words, they were a group of people who hardly drank coffee. So coffee drinking appeared to show causality or a strong association with pancreatic cancer. So one way of making sure that you are not making a spurious association or causation is look at the control group. Are the risk factors and the outcomes in the control group similar to the general population? If they are higher or lower, then possibly your control selection has been faulty. So to put this pictorially, on the left, it's a causal association. Let us say smoking is a characteristic under the study, and the disease is lung cancer. And you observe an odds ratio of 5. Say the odds of smokers getting lung cancer is 5 times the odds of non-smokers getting lung cancer. And you say that this is possibly causal. On the left, figure B, is what we really worry about. The characteristic under the study, let us say, is coffee drinking, and the disease is pancreatic cancer. And we find an odds ratio of 5. But is there some other story also going on? And that factor X, which is marked in the diagram, could be smoking. Perhaps smoking is associated with coffee drinkers, and smoking also causes pancreatic cancer. So the real story is that smoking causes pancreatic cancer. It just so happened that smokers drink more coffee, and you only picked up coffee drinking and cancer. So you missed the real story. So factor X is also called a confounder in the story. So that is an important part to think in mind when you find a strong association for harm or benefit. Is there some other story in between? As some other story is often called a confounder. Let's deal with some examples. The first example, coffee drinking causes pancreatic cancer. That's what we observe, a strong odds ratio. Then we go back and delve a little deeper into the story and we ask, how many of the coffee drinkers smoke? How many don't smoke? How many people with pancreatic cancer smoke and don't smoke? And then the real story comes out. It's really smoking which causes pancreatic cancer. And it just so happened that smoking was associated with coffee drinking as well. So an important principle in this figure B, the confounder, which is smoking, has to be associated with both the exposure or the risk factor, which is coffee drinking in this case. And it also has to be associated with the outcome of interest, which is pancreatic cancer in this case. In that case, that is called a confounder. How do you know you have a confounder in your own study? Well, you have to read a lot of literature, ask many experts in the area. I'm studying the effect of coffee drinking and cancer. Is there anything else I must measure? And anything else to measure is called the confounder. And if you take the smoking history, then your analysis or the statistician will be able to tell you that that is a confounder. Let's take another one. People always worried about heart disease. CHD is coronary heart disease. We worry whether high cholesterol causes heart disease. The story could be told slightly differently in figure B. Factor X could be physical inactivity, couch potatoes. Maybe people who are couch potatoes who sit and don't do much work, they have high cholesterol because they are physically inactive. And maybe physical inactivity causes heart disease. Because physical inactivity is associated with both high cholesterol and the risk of heart disease, it could be termed as a confounder. So it's very important, even if you have a strong feeling that cholesterol causes heart disease, to measure other risk factors which potentially could be confounders. Why should we bother about it? We all know that cholesterol causes heart disease. Does it make a big difference? As you as healthcare professionals and all of you are going to be health administrators, it makes a huge difference. Say, for example, if physical activity has been shown to reduce colon cancer, that's what we want to do. And then we make parks, we make walkways and tell everybody start walking, your risk of colon cancer will come down. And if it's true, then we as health administrators have done something good. If on the other hand, actually that association between physical activity and reduced colon cancer was fake. What do I mean by fake? There was a confounder, there was something else. Maybe people with increased physical activity eat more fruit and vegetable. And people who eat more fruit and vegetable are also those with less colon cancer. Then what we have achieved by increasing the walkways and parks is actually no benefit. You'll find people start to walk more, but actually, in fact, you'll find no benefit of colon cancer. So we may make similar changes in our hospitals, saying that this change will make an improvement in our patient outcome or in our patient services based on some wrong association, which we think is causal. So it is very important that we try to look at what else could be there in the story, and that what else is really the confounder. So we must distinguish between an association which is not causal and an association which is actually causal. And that difference is vitally important. Let me try and take you through some of these stories. Smoking is blamed for everything. Let's have a look. On the x-axis, you have the birth weight of babies. On the y-axis, you have percentage of children in that particular group. The smokers are in red and the non-smokers are in blue. As you can see, there are the babies who are born from non-smokers are heavier on average, and the whole distribution is shifted to the right as compared to the smokers whose babies are smaller and the whole distribution is shifted to the left. This is one bit of evidence that perhaps smoking causes low birth weight babies. But there is more to the story. Somebody would say, perhaps if you smoke, babies are born earlier and they have lower gestational age and therefore lower birth weight. So this is an interesting graph. On the x-axis is the amount of gestation before the baby was born, and the y-axis is the mean weight in pounds. And you can see, take for example, at week 37 in red, there were probably about 95% of babies with a lower birth weight, whereas the non-smokers had a much higher birth weight at the same gestational age. And if you follow the graph over time, you'll see that for every gestational age, the smokers tend to have lower birth weight babies as non-smoking mothers as compared to. A little bit more, if one were to look at a dose response, what do I mean by dose response? People who smoke only 20 cigarettes a day as compared to those who smoke more than 20, and compare them with non-smokers. So we have three groups: non-smokers, less than one pack a day, and more than one pack. Pack is 20 cigarettes. And if you look at the birth weight of these babies, we see a trend. The y-axis here is low birth weight, less than 2.5 kilograms. So you can see that from non-smokers to little bit smokers to lots of smoking, the amount of low birth weight keeps increasing in a graded manner. This is called a dose response. This is also suggesting that it's possibly causal relationship. The association is not spurious, it is possibly moving from association to causation. But there are many more things to be thought about, and this is where one must read a little bit more. So if you read more or talk to smokers, women who smoke during pregnancy or before pregnancy are less likely to use contraceptives or have a planned pregnancy. They are more likely to drink coffee or alcohol, whereas non-smokers tend to drink more tea or coffee, milk, or in Western countries, wine. Smokers tend to be a little bit more carefree and lead more extreme lifestyles. There are also some biological differences. There's a higher rate of twins among smokers, and the age of menarche is lower among non-smokers. So one could argue that it just so happens that smoking is associated with low birth weight, but it's actually the smoking, other habits which or other biological factors of non-smokers which really causes low birth weight. And cigarette companies use these arguments to say that smoking does not have any harmful effects. It's some other biology which makes you smoke, and that same biology which makes you smoke gives you a higher risk of various diseases. Let me give you another example. A famous scientist called Yerushalmi observed low birth weight babies, and he was interested in the future. So he followed up women from pregnancy and the future. So some people never smoked ever before or after pregnancy in the future. They were called non-smokers. The second group were people who didn't smoke during this pregnancy, but smoked in subsequent pregnancies or smoked in the future. Some people smoked during this current pregnancy and continued to smoke. They were called smokers. And some people are called future, or they smoked during this pregnancy and didn't smoke during future pregnancy. So looking at the behavior of smokers, and this is known to happen. People smoke, some start smoking, some stop smoking. But he looked at the current birth weight of those babies and compared what with their future status, which I've just described, the four groups. Let's see what the data shows. Interestingly, non-smokers who never smoked during this pregnancy or the future pregnancy had about the same percentage of low birth weight as women who smoked during this pregnancy but stopped in the future. Non-smokers who smoked in the future, they didn't smoke during this pregnancy, had the same amount of low birth weight babies as compared to women who smoked during this pregnancy and continued to smoke in future pregnancy. He suggested, looking at this information, that smoking has nothing to do with low birth weight. Currently, our understanding is that smoking does cause low birth weight. But I'm just putting out the story there that there are many things to consider before assuming that association is causal. And the future slides or the next part of my talk is really going to take you through some steps we use to make that leap from association to causation. So let's talk about causation. There are two types of causation. One is called direct causation. A causes B. And there's another one, there's direct, there has to be indirect, where there are some numerous steps between A and B. A directly doesn't cause B, it goes through a series of steps. And as you might guess, in human biology, most causation is actually indirect causation. A causes a change in something, which causes a change in something else, which then causes disease. Let me show that pictorially. On top is direct causation. The risk factor, whatever smoking, causes lung cancer. Below, the same risk factor, perhaps smoking, it causes some change in the body, which leads to another step in the body, and then leads to lung cancer. So our current understanding is that most risk factors cause indirect causality. There are four types now of relationships between the exposure or the risk and the final outcome, which is disease. And I'm going to spend some time talking about these four types of causal relationships. The first is called necessary and sufficient. The second, necessary but not sufficient. The third, sufficient but not necessary. The fourth, as you can guess, is neither sufficient nor necessary. I will take you through each of these in detail now. The first, you have a factor A which causes disease, the direct causality. And we say this is necessary and sufficient. The risk factor is necessary, meaning without that risk factor, you can never have disease. So that's called necessary. No risk factor, no disease. And what does sufficient mean? In the presence of the factor, disease is always present. Now, as you can think, that is not such an easy situation to get. It's very, very rare to have necessary and sufficient causes of disease. Take, for example, tuberculosis. If I have TB, will all my family members who live in my same household also get tuberculosis? Well, they don't. Why is that? We know that TB causes Mycobacterium tuberculosis causes TB. Some of the household family members may be immune to TB. Some may be more genetically susceptible. And there may be other characteristics which lets them develop TB or not. So getting sufficient and necessary, or necessary and sufficient, is quite unusual in actual medicine. The second one is this. There are three different factors, A, B, or C. Any of them could cause disease. And as you can figure from this figure, this fits into necessary but not sufficient. Each factor is necessary to cause cancer, but it's not sufficient in itself. One by itself cannot cause cancer. Multiple factors are required. Take, for example, any cancer developing. We know that in cancer, something initiates the cancer and then something promotes the growth of that cancer. And that initiator must happen first and then the promoter must come next. So in this time sequence, if the order is reversed, cancer doesn't develop. So the initiator and promoter are both required. They are necessary, but they're not sufficient in themselves to cause cancer. So most cancers, the carcinogenesis is multi-stage, having two steps. So necessary to cause cancer, but not sufficient by themselves. Take, for example, tuberculosis. Without TB bacilli, you can't have the disease tuberculosis. But many of us have TB bacteria in our body, but don't come down with the disease tuberculosis. So there must be something else. Your immunity must be compromised, or some other factor must happen for you to develop clinical tuberculosis. Another example, Helicobacter pylori is a bacteria which is seen in most Indian stomach, and it is said to cause stomach cancer or gastric adenocarcinoma. But we also know that most Indians don't have gastric cancer. So if it is so common and causes cancer, everybody should have cancer. So we know that, okay, it is necessary, but not sufficient. Something else must happen in addition to having the Helicobacter pylori bacteria to cause cancer. What is that something else? Perhaps it is smoking. Perhaps it is food rich in nitrates, or it is alcohol, or something else. So Helicobacter pylori is necessary, but not sufficient to cause gastric cancer. I can see that somebody suggested NSAID. Yes. So in addition to H. pylori, Helicobacter pylori, many other risk factors are also required. So it's a two-step process. So we say that H. pylori is necessary by itself, but not sufficient. The third way, factor A or factor B or factor C could cause disease. This is slightly different from the previous example. Any of these factors could lead to disease. So now we call this sufficient by themselves, but not necessary. So the factor alone can produce disease. So a factor acting alone, for example, we know that benzene exposure can produce leukemia without other factors. We also know that radiation alone can cause leukemia. So these are sufficient in themselves, but not necessary. Although it may not necessary, without benzene, you can get leukemia. Without radiation exposure, you can get leukemia. Without benzene or radiation exposure, you can get leukemia. So these are called sufficient causes, but not necessary to cause disease. So this is called the sufficiency alone criteria. It's not very common to find diseases which are caused by a single sufficient cause. It's a little unusual to find them. The most common is this, what appears to be a complex picture, is 2 or 3 factors which are required to cause disease. It could be factor A and factor B, which together cause disease. Or it could be factor C and factor D, which cause disease. Or it could be factor E and factor F, which cause disease. So it looks complicated, but let me break it down slowly for you. So this is the last criteria, what I showed you in the previous picture, neither sufficient No single factor is sufficient by itself to cause cancer, and no single factor is necessary by itself to cause cancer or some other disease. It is a complex model, but it most accurately reflects most disease causations, at least of non-communicable diseases, hypertension, diabetes, ischemic heart disease, cancer. So it's important that we spend some time to look at this. For example, CHD or coronary heart disease or heart attack or ischemic heart disease, different names. There are various combinations of things which can cause it. Take the first one, people who smoke, who also have diabetes, who have low levels of high density lipoprotein are at high risk for cancer, for heart disease. That's one group. Another set of people may have high total cholesterol, they may have hypertension, and they may have physical inactivity. And this group is also at risk for getting coronary heart disease. So you see that none of these individual factors is sufficient by themselves, and none of them by themselves are necessary. So a conglomeration or a group of these risk factors together can then cause disease. Let me show this to you in another method of another pictorial form. Kenneth Rothman liked to use these Venn diagrams to explain the same thing. On the left, figure A, people with diabetes, high density, low or high levels of low density lipoprotein, and genetic susceptibility. They can get ischemic heart disease. Another group of people who smoke, low levels of high density lipoprotein, hypertension, and physical activity. They can also get ischemic heart disease or coronary heart disease. So this is probably the most accurate method of looking at causality for most diseases. So Rothman's idea was a sufficient cause. Instead of saying a single item is a sufficient cause, is really a constellation or a group of risk factors. So he used to call this component causes. So if I was to go back, all the factors in one single Venn diagram are component causes. Diabetes, high LDL, and genetic susceptibility together are called component causes. And together they become a sufficient cause for causing disease. So this is one way of looking at causality. So what was the historical idea of causality before this? In the 18th centuries, most people died of infectious diseases. And so the idea of causality was propounded initially based on the diseases of which caused infectious diseases. In 1840, Henle and subsequently Robert Koch in the 1880s came up with the famous Koch's postulate. The organism is always found with disease, like Mycobacterium tuberculosis. Always you'll find TB bacteria. It's not always true that you'll find it, but the TB bacteria is always found with disease. The organism is not found with other disease. In other words, Mycobacterium tuberculosis shouldn't be associated with cancer or heart disease. The third criteria, you take the organism from one patient or an animal with disease, and you take it and put it into some other animal or subsequent generation of animal, and it should cause disease in that animal. Criteria 4 was added on by Robert Koch to say that even if the criteria 3 could not be shown or proven, if criteria 1 and 2 are there, then we can still say it is causal. These are commonly, in colloquial terms, referred to as Koch's postulates. But as we can see from our previous 4 models of causation, this doesn't work for non-communicable diseases. In fact, even for tuberculosis, just having the TB bacteria doesn't mean you have disease. So the world has moved on from the Koch's postulate, and I'm going to take you through the current understanding of how we look at a more definite way of causality. The US Surgeon General was asked to adjudicate whether smoking causes lung cancer because it was a big deal. It's a lot of money to be lost by the smoking companies, and the patients would sue the companies if it was shown. So how did they go about it? Why am I taking this as an example? I'm using this as an example so that when you are at your own place of work and you're making decisions, you can use the similar principles that these people use in the US. and many people use in decision making regarding thinking of something as being causal. So these are 10 or 9 principles which are often used in current medical world to say something is not just an association but causation. There are 9 of them, and I'm going to take you through each of them in sequence. So the first one says temporal relationship. So what do I mean by temporal relationship? The risk factor which you think caused disease should have occurred before the disease happened. That sounds very silly, that's obviously intuitive. But if you did a study design called cross-sectional disease, where you studied the disease and the risk factor at the same time, it's very difficult to conclude that A caused B because you studied both at the same time. Let's look at this picture in the graph here. On the x-axis are the days or time, and on the y-axis is the density of dust particles or smoke particles in the air in London in the 1950s. And follow the red graph, the red line first, that is the dust particles in the air in London at that time. And you can see the dust went up for some time, and then over some time, due to some occurrences, the dust amount came down. The blue graph is deaths in London at the same time. And as you can see, subsequent to the increase in the smoke concentration in the air in London in the 1950s, the number of deaths went up. And as the smoke levels started to come down, subsequent to that, the number of deaths also started to come down, and both seem to mirror each other. So the smoking, as we said, came first, and then the deaths came. So therefore, we say that this suggests a temporal association. Smoking came before the deaths, and there seems to be a relationship between the two. Now, as I said, in a cohort study where you follow up people, you have the risk factor first, and you know people don't have the disease at the time they're exposed to the risk factor. You follow them up for disease. Proving this temporal association is easy. Whereas, if you do a cohort, retrospective cohort, or a case control study, where you have people with disease, and you're asking them about past exposure, were you exposed in the past to something, a risk factor, let us say smoking or coffee drinking? We are relying on data from the past, which may not be accurate, unless you have written records or documented evidence which is collected for some other reason. The case control study or retrospective cohorts face this problem that they can't show temporal association because the exposure was not accurately measured in the past. So the order of occurrence has to be important. The second thing is biology. For example, we know that if you're exposed to asbestos, either asbestos roof or more in environments with high asbestos, you can develop lung cancer. But it doesn't happen overnight. If you're exposed to a lot of asbestos, it takes about 15 or 20 years before lung cancer develops. That's the biology of asbestos and lung cancer. So if somebody had lung cancer and 3 years earlier was exposed to asbestos, we have to ask ourselves, perhaps this asbestos did not cause the lung cancer. The temporal association doesn't seem to fit the biological profile that we know. The second is called the strength of the association. And what do I do? To recap again, association means relative risk or odds ratio. Generally, an odds ratio relative risk more than 1 means protection, whereas less than 1 means harm. It all depends on what you choose to put as a numerator and what you put as a denominator. Relative risk odds ratios more than 5, 10 suggest significant harm or protection, and less than 0.5 again significant harm or protection. So for example, if you take a look at people who have very high blood pressure as compared to normal blood pressure, the risk of the people with very high blood pressure developing stroke is 5 times more than those who have normal blood pressure. So you would say the relative risk is 5. So relative risk of 5 suggests, oh, there's something more than just an association. Perhaps it is causal. So high levels or very low levels of relative risk or odds ratio could suggest causality. The third point in the 9 points which are used currently to determine causality is called dose-response relationship. And I have shown this picture, another dose-response relationship earlier in my talk. This is commonly used example, smoking and lung cancer. And we know that if you smoke 20 cigarettes for one day, for a year, every day for a year is called one pack year of smoking. So repeating 20 cigarettes a day for one year is one pack year. And the x-axis is looking at the pack years of smoking. On the y-axis is looking at your mortality rate. And as you can see, compared to people who never smoked and then less than one pack year in their life, more and more and more. As the number of pack years of smoking goes up, your mortality rate also goes up. So this shows a clear gradient or a dose-response relationship. This suggests causality. But there's always a but for every story. It's not always true. Some risk factors have a threshold, meaning that a small amount will not cause disease in anybody. And there has to be a tipping point or a certain amount or a certain level of exposure above which it causes disease. So in that kind of situation, you may not be able to demonstrate a dose-response relationship. But at a certain point only, disease will start to appear. So while it is interesting or nice to have a dose-response relationship, it is not essential. Replication of findings. Now, this is this probably cannot be stressed more, and we are well aware of what appears to be fantastic scientific discoveries, which nobody is able to replicate in future, and those great discoveries die off. So, if you really want to know if something is causal, you find some evidence in your own area, look and see if somebody else has found similar results for the same exposure in another part of the world, in a different population, different socio-economic situation. And if you find that many people are finding the same association all over the world, then you say it's replicable. This seems to happen everywhere. Unless you have a strong biological reason or other reason to say that I don't expect this finding to happen elsewhere in the world. If you have such a reason, then okay, we can't go on replication. But generally, you should be able to replicate your findings, or they should find somebody else who has had a replication of your findings before you jump to say that A causes B. Biological plausibility. This means we are able to understand what's going on. For example, we'll say that cigarette smoke contains this harmful chemical. This harmful chemical will go into the lung and it will cause a change in the DNA of the cell. And that DNA change will then cause cancer. So we have a process or a pathway which we think we understand, which causes cancer, link between smoking and cancer. This is called biological plausibility or our understanding of the biology of disease. It is very nice if we can make a logical sequence of this. But we know from previous experience, for example, somebody observed many babies with congenital cataract, meaning they were born with cataract. And then they looked and found that many of those mothers had rubella during pregnancy. At that time, nobody even knew that there was a virus or the viruses can be teratogenic. So there was no biological plausibility, but people still found the association. Many babies are born and they quickly have visual impairment or retrolental fibroplasia, basically fibrous tissue behind the lens of the eye. And somebody noticed that these are all babies who were born prematurely, and the hospital gave high levels of oxygen to those babies. People did not have a biological explanation how high oxygen levels can cause this particular disease. So even in the absence of a strong biological rationale, we may still find associations which are actually causal. But human being needs to have some explanation for what happens. So if you don't have a biological explanation for A and B, which are associated strongly, but you can't explain the causality, then we tend to be a little bit more finicky. What do we mean by more finicky? We expect a much higher odds ratio or relative risk before we say causality. We will definitely say, has other people also found this? Has it been replicated elsewhere? So we put more stringent criteria to say causality when we can't give a biological explanation for what we have found. But that does not mean it's not causal. Very often it is causal. It's just that we can't explain it at that moment. Consideration of alternative explanations. So have you thought what else can cause between A and B. For example, some people strongly believe that alcohol consumption causes ischemic heart. If you look at the odds ratio relative risk, it may be high for causing disease or association being high. But if you go and observe the behavior of many people who consume a lot of alcohol, they also tend to smoke at the same time. So smoking was a confounder in that story. Smoking is associated with alcohol consumption, and smoking is associated with ischemic heart disease or coronary heart disease. So if you had not gone and found an alternative explanation, gone and observed human behavior, then you would come to the wrong conclusion that alcohol is strongly associated with coronary heart disease. So that's something to keep in mind. Is there some other explanation for what finding or phenomenon that I am finding here? The next important thing is called cessation of exposure. When you stop the exposure to somebody, does the disease go away or decrease? So we know that on the x-axis in this picture is the years since people stopped smoking. And if you look at the y-axis, it is deaths which happen every year, annual death rate per 1,000 people. And as you can see from this figure, the figure is gradually decreasing. Meaning, from the time you stop smoking, the annual death rate starts decreasing. So we can then conclude that perhaps smoking caused increased mortality because stopping smoking seems to decrease annual mortality. So this is another way of trying to look at causality. So this is what I explained, that if the factor caused disease, and if you reduce the factor or take away the factor, the disease should disappear or decrease. Let me show some natural experiments. We didn't do an experiment. Things happened and we looked at it. This is the story of Cuba. On the x-axis is time, and on the y-axis are different disorders. So I'll just take you through the top one. And I want you to go back and look at these slides because it's a very interesting story. During the time which is dark gray in the middle of this, there was an economic crisis in Cuba. Because of the economic crisis, there were severe food shortages in Cuba, and people did not have enough food to eat. So as a result of this, obesity levels of people's body mass index and weight came down dramatically because there was no food to eat during that time period. So let's look first at the top line. The top graph is diabetes. You can look at the trend before the gray part. Diabetes levels start increasing because even in India, diabetes is increasing because of increased affluence, decreased exercise, various other factors, diabetes is increasing. During the time of the economic crisis in Cuba, diabetes levels remained static. They didn't keep increasing. And subsequent to that, diabetes levels actually started to decrease. So you can see the effect of reducing calorie consumption. So we didn't forcibly do that. It was a natural experiment. We have nothing to do with it. We're just documenting that in Cuba, because of the economic crisis, there was not enough food, and diabetes levels start to come down. And the same story reflects in figure 2, which is coronary heart disease. But there's no change in cancer, which is the figure 3. And so we can use, the story I'm trying to say is that natural experiments can also be used to make some inferences. This is another example of, in the 1990s, people in the US started having body pains, aches and pains, unexplained aches and pains in large numbers. And the only odd thing was most of them had a high eosinophil count at that time. So people call this eosinophilia myalgia syndrome. There was a supplement called L-tryptophan which was available in the market. And scientists began to study if L-tryptophan actually was causing eosinophilia myalgia syndrome. And you can see that this x-axis is the time and the y-axis is the number of people with this eosinophilia myalgia syndrome. So you can see from the graph that in the beginning of the graph, prior to 1988, Very few cases of this syndrome were described. And by mid 1989, there was a huge explosion of eosinophilia myalgia cases. And you can see from the graph, the arrow mark, where the arrow mark is put on the graph in 1989, the FDA, the Food and Drug Administration of US, banned L-tryptophan sales. And the moment that was banned, the eosinophilia myalgia syndrome cases came down dramatically. So withdrawal of the exposure seemed to suggest decrease in disease, suggesting that perhaps L-tryptophan was a causative factor in eosinophilia myalgia syndrome. The next factor which people look at is called consistency with other knowledge. Can you show that the same exposure causes disease in many different types of people or in subgroups of people? Then we'll say, okay, yeah, this is something we tend to think is consistent with our other knowledge. In this graph, purple is smoking in men and blue is lung cancer in men. And you can see that as smoking increases in men over time, lung cancer also increases in men. So that's something we're happy about. The red line is smoking in women, and the greenish blue line in the bottom is lung cancer in women. Now we say that, okay, we found out that smoking is associated with lung cancer in men. The same story also seems to happen in women. Then we say this is consistent knowledge. We are finding some consistency in the story across different subgroups or groups of people. The finding should be consistent with other data. But this is not such a very important finding among the 9 points which I mentioned. The absence of consistency doesn't mean that it's not causal, but it's a nice thing to also have to prove causality. The last point, or among the last points, is called specificity of association. One exposure should cause only one disease. The MTB bacteria should only cause the clinical disease tuberculosis. That may sound reasonable. But think about smoking. Smoking is known to be associated with lung cancer, pancreatic cancer, bladder cancer, ischemic heart disease, and chronic obstructive lung disease or COPD. Now we can't say that this specificity applies to smoking because smoking seems to cause many diseases. So the factor of one factor causing one disease only is a bit weak, and probably among the 9 factors mentioned is the weakest factor for proving causality. These 9 factors were also one of the major propounders of this was Austin Bradford Hill, an epidemiologist. And many people often call these 9 factors Bradford Hill's or modified Hill's criteria for causation. So if you hear the word, these are the same 9 factors. But this is what Bradford Hill actually had to say about his 9 criteria. We should look at all 9 aspects. There is no hard and fast rule. There are 3 out of 9 or 6 out of 9. So there's no hard and fast rule as to the number of factors. No single factor should be taken. You shouldn't say, 1 out of 9 is enough. There's no single factor as evidence of causation. These 9 factors all together should help us make up our mind about causation. And we should always have in the back of our mind, is there some other explanation for the facts before me? Often people jump to conclusions about causation only to be proven wrong, mainly because they didn't ask this question, is there some other fact to explain what I am finding here? So this is an example which I'll take you through. It is H. pylori and peptic ulcers. The 2 Australian doctors who discovered H. pylori got a Nobel Prize. They were the first ones to show H. bacteria in the stomach and then culture it, and then lots of diseases have been shown. So what criteria were applied to show causation between H. pylori and peptic ulcer? First, temporal relationship. So we know that people who have H. pylori without gastric ulcers then go on to develop gastric ulcers. Strength of the association. Well, that's also easily provable. We know that people who have H. pylori are much higher chance of getting gastric ulcers or peptic ulcers as those who don't have. Dose response relationship. It is possible to quantify the level of H. pylori in the stomach, and it is shown that people with much more H. pylori level seem to have much more. Replication of knowledge. Now, this H. pylori has been found in all populations of the world, and there is a similar association between peptic ulcer and H. pylori is shown in different subpopulations in different parts of the world. Biological plausibility. Now, for the longest time, we know that, let us say, 70% of Indians, up to 70% or even more, may have H. pylori, and all of us don't have peptic ulcer. How can we say peptic ulcer is caused by H. pylori? So there was no biological explanation. But now we know that there is a mechanism by which H. pylori can increase inflammation of the stomach and reduce the protection of the stomach against its own acid and cause disease. Alternate explanation. We also know that many people have H. pylori, but all those people don't get peptic ulcer. So you need one more factor, which I mentioned among the factors. Probably you need to have smoking or NSAID or something else along with H. pylori to get ulcer. Cessation of exposure. Now, very often people are given 3 or 4 medication to get rid of all the H. pylori in the stomach, and you can find the peptic ulcer goes away. And in people in whom the H. pylori doesn't come back, the ulcer doesn't tend to come back either. Is this consistent with other knowledge? Does it happen the same in men and in women? Yes. So we can say it's consistent. Now, specificity of does H. pylori only cause duodenal ulcer? Well, it can cause duodenal ulcer, it can cause gastric ulcer, and now people are saying even gastric cancers. The specificity may not apply. But if you look at all 9 points together, one gets a reasonable assumption, or we can make a reasonable conclusion that H. pylori is associated or causes peptic ulcer. It may not be both necessary and sufficient by itself, but it is there in the causal pathway. Let's look at cohort data. You follow up a group of people and you see how many of them get gastric cancer. And you find that among those who are H. pylori negative, the chance of being cancer-free is almost 100%. Whereas those who are H. pylori positive, the chance of being cancer-free, the y-axis is being cancer-free. So the top of the y-axis, the 1, is 100% cancer-free. And you find that the H. pylori positive people, after a few years of follow-up, they start developing gastric cancer. So this is one way of looking at the same thing which I said of the temporal association. Another method, another example which is commonly quoted is age of alcohol, initial drink of alcohol, and the lifetime alcohol abuse. Let's break this down slowly. On the x-axis is the drinking onset age. Some people start drinking as early as 13. Some people start drinking at the age of 21. And on the y-axis is the prevalence of lifetime alcohol abuse. We could say, in a way, being dependent on alcohol. And I can see from this figure that people who start drinking at the age of 13 as compared to people at the age of 21 are much more likely to have a lifetime alcohol risk abuse, higher chance of alcohol abuse throughout their lifetime. Now, this may have many explanations and this may not be directly causal. But these are some things which people look into, and people have decided that looking at this evidence is strong enough to increase the minimum age of drinking to 18, or some countries even have 21. With the hope that if you increase the age at which people start drinking, then the lifetime risk of alcohol abuse will come down. So the US has guidelines on causal inference, has 2 criteria or 2 steps they use. One is the quality of the information that you have taken, or the quality of the data. And the second is the criteria. And the criteria are the Hills criteria or the 9 criteria. I just want to impress upon you that you must be very careful about the quality of the data or the studies from which you are making those inferences. And that's very important. And this is what I mean by quality. We don't have to go through the whole steps. But in the US guidelines, they mention that if you have got good quality trials, that's called high quality evidence. Whereas if you just have a case series or 10 patients with a disease, the quality of the evidence is low. So you can go from 1, 2, 3, 4 in this table, which I will leave with you, that you know that the quality of the evidence could be high quality or low quality. And you tend to make causal assumptions when the quality of the evidence is high. So that's important. First, look at the quality of the evidence. The second is once you set the quality criteria, then you say what are the causal criteria you're going to use. And the US guidelines has divided them into major and other. And if you look at these criteria, temporal relationship, biological plausibility, consistency, alternate explanations or confounding, then dose response, strength of the association, cessation of effects. These are basically the Bradford Hill criteria. And the US has, for this particular disease, they have decided that these are the order in which the importance are going to be given. But I would suggest that you take all 9 criteria and apply it to what situation you're facing and look at the totality of the evidence before you make a decision about association or causation. But like I said in the previous slide, first look at the quality of your evidence. So, for example, these are some tables taken from the US Preventive Services. One is high quality evidence. The available evidence indicates consistent results from well-designed studies representing primary care populations. These studies assess the effects of preventive services on health. The conclusion is unlikely to be strongly affected by future studies. What it's telling you is the conclusion we have made on causality is based on high quality studies in the population that we are interested in primary prevention. And it's also telling you that we don't need to look for more studies because the evidence we have is so strong that we don't think future studies will change our opinion about what we think now. So we can look at the quality of the evidence as being high quality evidence, moderate quality, low quality. And what is low quality? The quality of the studies is poor, and we cannot be sure at all that future studies may actually change our opinion on what we think is causal to non-causal. So we need more studies before we can make any conclusion. So there are high quality studies which will tell us we don't need further evidence. Low quality evidence could be poor quality studies, or the population is different from what we want to look at, or it may have been the data itself is very poor. And we then conclude the low quality studies that we can't be very sure. Future evidence may change what the current evidence seems to suggest. And the moderate evidence is somewhere in between high quality and low quality evidence. Now, I want to just spend a few minutes on disease pathway. So, in black, you can see in this picture, people at risk for developing disease. If you have people at risk for developing disease, then you can target them. For example, people who smoke, physical inadequacy, diabetes, you target them. Then the first red box is early detection of the target condition. Let us say it is ischemic heart disease. Is there some way to detect it before people get signs and symptoms? The next red box is intermediate outcome. Let us say I look at your heart function using a test called echo. That's an intermediate function. It is just telling me how your heart is functioning, not how you feel or how long you live. The last box is reduced mortality or mortality. That is how long you live, your mortality, and how you feel. That's a real hard outcome. So you have people on the black side end of this graph or the line which are at risk for getting disease. Then some people whom you can detect the disease early. You have intermediate outcome for the disease, which are just lab tests usually. And then you have the final outcome of the disease, which you really want to get. I'm talking about screening now, the benefit of screening people. Screening can have many connotations. Maybe you're screening people for the risk factors of disease. Maybe you're screening people for early detection. Even before they have signs and symptoms of disease, you want to pick them up. Or you want to pick them up once they have an echo finding or intermediate outcome, and you want to reduce the progression to actual symptomatic disease or mortality. So all these could be thought of as screening. And I mentioned to you the benefits of screening somebody. But we also know there's nothing without a price. So you may think that if I screen somebody, let's say I'm screening you for memory loss or dementia. If I screen you early, very good. But if I screen you for memory loss early and there's no treatment for it, what benefit have I given you? Nothing. You're going to be sitting around thinking, oh, I'm going to keep losing my memory. You may stop doing many things which you're doing otherwise. You may reduce your social activities. You may go into depression because I found out some disease for which nothing can be done. So there are always adverse effects to picking up some disease early. Usually when you can't do anything about it, then that's a problem. Second problem, you diagnose somebody with, let's say, heart disease very early and you put them on some medication. No medication is without side effects. And patients may suffer side effects of medications for a disease for which they didn't even come to you in the first place. You screen them for a disease and picked it up very early. So there are adverse events of early treatment as well. So now you can see there's benefits to screening and there are also overall harms to the entire screening process. So why is that important? So one could think of on the pink boxes going across from left to right, magnitude of net benefit. Magnitude of net benefit meaning the benefit is more than the harm. And substantial means the benefit is substantially more than the harm. Then moderate, then small, then zero or negative meaning the benefit, the harm may be more than benefit. On the other column is the certainty or the quality of the evidence. And high means this is good quality evidence for which we can strongly believe. This evidence is something believable. And low means that the studies are so poor quality we may not be actually able to believe them. Then we can make a grid like this and we say that, oh, okay, for example, box A. Box A means substantial evidence of benefit for this screening process or whatever preventive services you may want to give in your hospital. And that's coming from high quality evidence. Okay, this is very good. Now I'm very sure about this and the evidence is good. Let me introduce this new practice. And the criteria for net benefit, like how did we come across this criteria for A, B, C, and D? This is a particular table. I'm not interested in taking you through the whole table, but I put it here. You can have a look at it in the future. But it's basically, you must have some criteria in your mind. Okay, when am I saying the benefit is more than the harm? And once you've decided that, you must also look at the quality of the evidence before you make some changes based on your causal inferences. In conclusion, I just want to go back to where we started. You are already aware of different types of study designs. And the whole goal of epidemiology is to reduce human suffering. How do we do that? By studying various diseases. How many diseases are there? Who are the people who get certain diseases? And then we look at what are the possible risk factors for those people who have disease. And once we establish that as association, we then want to show it's not just association but a causation. Once we say that A causes B, then we want to know whether if we reduce A or treat A or take away A, it will reduce B. In other words, if we take away the exposure or treat the exposure, the disease will become less. And that's what I meant by screening and preventive services. Before we jump to that step in the biological inference pathway, we must put some criteria. And one is the quality of the evidence. And secondly, the net benefit or harm of what we do. Just remember that nothing we do comes without a price, either it's cost or some other side effect. And that must also be taken into account when we make biological inferences. Some of the top ideas which I would like you to read further, and the reference textbook for this talk has been the Leon Goddess textbook of epidemiology, is one which I have mentioned repeatedly in my talk, which is called confounding. At the beginning of my talk, I mentioned confounding. And I would urge you all to look at confounding, read some more about confounding. The second topic is bias. By bias, I mean things which take you away from the truth. We assume there is a truth in a situation. Whether smoking causes lung cancer or it doesn't cause. That's a truth which we think we want to establish. And anything which takes you away from the truth is called bias. What to explain that in a few lines, poorly done studies tend to give you wrong results. Usually they're very high odds ratios or very low odds ratios. So bias is looking at the risk of poorly done studies. So I would urge you to read a little bit about bias in studies. And something which I felt was beyond the scope of today's talk is interactions. What happens when two factors interact in the causation of disease? When do we say it's a confounding factor and when it's interaction? Probably beyond the scope of today's talk. But I just want to say that for future reading, that if you're interested, have a small read about interactions versus confounding. Read a little bit about bias. And a good reference for all these is again the Leon Goddess chapter, book on epidemiology. So I will wait now for a few minutes. If you would like to ask me any questions, doubts, I'll be happy to clarify. If you have none, you can post it on the web for the next week or so, and again be happy to clarify with you. Yes, chapter 14 and 15 from the book. The book which is mentioned in your notes or chapter edition 4 of Leon Goddess. Currently, there's an edition 6 of the Leon Goddess book, and it is much easier to look at and read. And I would urge you all to purchase this book. It is available on different electronic or other bookstores in India. Chapters edition 6 of the Leon Goddess and chapters 14 and 15.